This is Dr. Loy with Drs. Owen, Gutman, and Reed presenting our technique for superior capsular reconstruction at the Taos Orthopedic Institute in Taos, New Mexico. We have a 68-year-old right-hand dominant female that presents to the clinic with shoulder pain and weakness, and as the MRI demonstrates, we have a probable irreparable rotator cuff tear with chronic attributes of retraction and atrophy. The patient was taken to the operative theater for superior capsular reconstruction. We prefer to perform the SCR in the beach chair position with 6 standard portals and accessory portals as needed. We use standard posterior and anterior portals, a lateral 50-yard line portal, anterolateral and posterolateral portals just off the edge of the acromion, and an advisor portal. As we begin the case, you can see significant retraction of the rotator cuff beyond the level of the glenoid and a bare greater tuberosity, indications to proceed with a superior capsular reconstruction. We find it important to evaluate the cuff anteriorly and posteriorly for any healthy remaining tissue for possible future side-to-side repair. Soft tissue about the glenoid is removed to create a bony bed for placement of glenoid anchors. The passport cannula can be used to retract and protect against soft tissue entrapment. Once the anterior medial row swivel lock anchor is in the humerus, which is loaded with fiber tape, we use the sutures to measure the dimensions for the graft. We measure anteriorly. The process is also repeated laterally. Then we place the medial row anchor in the humeral head, again loaded with fiber tape. With the posterior medial row anchor in place, we measure posteriorly. Then we move on to the medial measurements, which may require a crochet hook or a specific arthroscopic measuring device. With the dimensions of the graft measured, we prepare the graft on the back table, usually adding about 4 millimeters to each measurement to ensure our sutures don't rip through the graft. To further reinforce the graft, we run a fiber tape suture along the periphery of the graft as a rip stop. To facilitate shuttling these sutures, we use a sterile leather punch to perforate the graft for easier suture passage. We also place 3 cinched fiber snares medially to assist in advancing the graft, and we place 3 fiber links uncinched for future passage of the medial row fiber tapes. While an assistant is finishing the graft prep on the back table, the surgeon proceeds with passing sutures in the anterior and posterior cuff tissue for future side-to-side repair. The anterior sutures are then docked, and the process is repeated posteriorly. Next, the glenoid is drilled sequentially, anterior, middle, and posterior. For the middle anchor, we use a knotless corkscrew which can assist in tensioning the graft. We then prepare the greater tuberosity footprint with a power pick. With the 3 medial row anchors now in place, the fiber snares attached to the graft are shuttled out the anterior, advisor, and posterior portals for future graft advancement. This is not the time to rush. It is imperative to make sure that these sutures that are used to shuttle the graft into the subacromial space do not become tangled. To prevent suture entanglement, we roll the graft and advance it with a cuff grasper through the 12x3 cannula. The larger 12mm cannula facilitates graft passage without soft tissue entrapment. We then advance the graft with even tension into the subacromial space. The middle anchor with a knotless corkscrew is provisionally tightened before the anterior and posterior push locks are advanced. The middle anchor sutures are maintained in the advisor portal for final graft tightening at the end of the case. The anterior glenoid push lock anchor is placed, followed by the posterior anchor. As where the anterior and posterior medial row anchors are required to be placed early on in the case so as to be able to measure the dimensions of the graft, we find it useful to place the middle medial row anchor now to decrease the complexity of suture management. We then shuttle the medial fiber tapes through the lateral aspect of the graft with the uncinched fiber links that were previously placed in the graft on the back table. This process is repeated for all 3 medial row anchors, preparing for a 3x3 expanded speed bridge type double row repair. With the medial row fiber tapes now passed, the desirable reduction is confirmed before placement of the lateral row anchors. It is important to visualize the anterior and posterior aspects of the graft at this point to ensure that future side-to-side repairs can be completed. With the graft reduced, the lateral row anchors are placed. A kingfisher or cuff grasper can be used to aid in the reduction of the graft to minimize dog ears. This process is repeated for the middle and posterior anchors of the lateral row, creating an expanded speed bridge construct. Here you can see final tensioning of the 3.9mm knotless corkscrew anchor in the 12 o'clock position of the glenoid. With the lateral row complete, we can turn our attention to the side-to-side repairs where the pre-docked sutures are passed through the Arthroflex graft. This is done for 2 sutures anteriorly and 2 sutures posteriorly, and then arthroscopic knots are thrown. Upon completion of the superior capsule reconstruction, the graft is visualized, confirming desirable reduction of the graft. The portals are closed in standard fashion, and the patient is placed in a shoulder immobilizer and sent to the PACU. This completes the Taos Orthopedic Institute's technique for superior capsular reconstruction. Thank you for your attention.